So now we see, as far as neuro-ophthalmology is concerned, it is one of the easiest exam cases. You can always get through in the exams once you get a case of sixth nerve palsy, third nerve palsy. Common questions only they will ask you. Okay? Suppose a patient has come, most important is complaints and examination systems, examination patient. What are the complaints now? Only we get what are the complaints now? Visual loss. See, if you ask a question of visual loss, you can yourself come to a conclusion. This is the most probable reason. Etiology. I tell you, visual loss, sudden, patient comes to you. Think he is having an inflammatory problem like optic neuritis or an ischemic problem. Sudden occlusion, whatever thing is there. If it's gradual, think he is having some toxic problem like ethyl alcohol, consumption of ethyl alcohol. Okay? Or it's a compressive problem. Any tumor compressing your visual system can be the gradual loss of vision. Whether you can come to a conclusion just by asking a question, is it gradual, is it sudden? Next you have to ask, is it unilateral, bilateral? Unilateral, think it's a case of optic neuritis, common. Whereas it's a bilateral visual problem, very rarely you can have bilateral optic neuritis. But most important, about the chiasma. Chiasma and above is a lesion. And another important question, you must always remember in young adults, think about Davick's disease. We have got neuromyelitis optica. This patient will manifest as, please remember, sudden loss of vision in both eyes. In children, if you think, nothing wrong in telling the answer as optic neuritis. In children, bilateral optic neuritis is very, very common. Because after viral infections, all these things. That's why always ask sudden, gradual, unilateral, bilateral. Another thing is that when you ask the patient, he will tell you, yes, the visual loss gets deteriorated. After taking exercise or after increase the body temperature, everyone knows that is Uthoff's phenomenon. Remember I told you on 5th, of course some of you might have attended, the reason for Uthoff's phenomena is some chemical changes or substances are getting liberated in the axonal areas. How to follow? So that chemical environment is changing, that's why the conduction is delayed. If you tell that, there's enough answers. Another answer you can tell, because of increased body temperature, the demyelinating plaques become edematous and compressed optic nerve. The axons are compressed. Thereby more, the problem is increasing. So if you have answer, suppose you ask the exams, what are the causes for, what are the reasons for USOFs? You just tell these things. One, chemical environment, and two, compression by the demyelinating plaques. This is a common question we ask in examinations. Then another problem, they will come to you, transient loss of vision. That patient will tell you. Not only visual loss, they will tell you transient loss of vision. Just ask questions. Transient loss of vision lasting for a few seconds goes in favor of papilledema, raised intracranial pressure. Transient loss lasting for minutes, you think it's a case of migraine. Now you have to ask the lady question, what? Are you getting any scintillating scotomas? And you know what is tecopsia? Tecopsia, T-E-I-C-H-O. Tecopsia means scintillating scotomas. That means you have to ask the leading question, are you getting tecopsia? That is scintillating scotoma. If it is so, it's a case of migraine. That's a transient loss. Another common question asked in exams, doctor, what are the common causes for transient loss of vision? Of course you know that, migraine, you know papilledema, but never forget about initial stages of angle closure glaucoma. Never forget that. Commonly we miss. Please remember, you can tell early stages of primary angle closure glaucoma patients can produce a transient loss of vision symptom. The common thing. Of course I told you, toxemia pregnancy, temporal arteritis. These are all various causes for transient loss of vision. Transient loss of vision may be toxemia pregnancy. Never forget that. It's a lady patient. You have to tell in the exams. Instead of temporal arteritis, ischemic optic neuropathy, all these things are supposed to produce a transient loss. Understand now? This is the way you have to answer the exams. Transient loss. See now. Next question I have to ask is pain. Pain, visual loss, movements problem. Movements, pain is increasing. It is optic neuritis. You know that. Pain increasing on movements with a visual loss. Painless, please remember. Of course, pain is there, unrelated to movement, something like this, it is intracranial problems. Intracranial problems. Understand now? Pain is there, visual loss, movements, yes, eye problem, optic neuritis. Pain is there, understand now? Visual loss is there, but please remember, unrelated to pain. It is mostly intracranial. Another thing is the devolution. Devolution is there, not the point. Devolution is there, pain is there. You have to know something about painful ophthalmoplegias, like Tola-Sagan syndrome. Never forget diabetes. Never forget diabetes as a cause for painful sudden loss of vision. Diplopia. Okay, and diplopia itself we can ask few questions. It is monocular, only one eye diplopia is there. It can never be a case of neuro-ophthalmology. Binocular, yes. Both eyes open, is having diplopia. It mostly is a case of neuro-ophthalmology problems. The another way you can easily come to a conclusion, diplopia more on up and down. It is third palsy or a fourth palsy. Diplopia on horizontal positions more. It's a sixth palsy or internuclear ophthalmoplegias. Or to follow. Rather you can just ask the leading question, you can tell these are various problems. Of course they can have a history of flashes. Flashes on movements of the eye, it is vitreous. Flashes unrelated to movements, it is something occipital lobe problems. Sometimes you can have occipital lobe problems, like in some irritation, all these things, they can have flashes. So always remember, flashes on movements, it is vitreous. It can never be a case of neuro-ophthalmology. Okay, then you see now, you are going to see the patient coming out. Okay, now a patient comes to you, man. He is entering outpatient department. Just see the patient. Okay, whether he is having hemiplegia, suppose gait is there, hemiplegic gait, think he is having, please remember, suspect third palsy. You can have Weber syndrome. You see the patient now, he is having tremors and all, he is coming inside, think he is having third palsy, maybe Benedict syndromes. Please remember. Okay, then another thing is that patient is having a head posture, chin elevated, think is having elevated palsy, chin depressed or palsy, a turn, it's a horizontal problems, tilt, vertical muscle, particularly we have got oblique recti, superior rectus and all these things. Always remember, one clue I told you, suppose my right side superior oblique is palsy or right side superior rectus is palsy, the head tilt, not the point, they are all intertors, man. So head tilt will be towards sound side. Superior muscles paralyzed, named muscles are paralyzed, head tilt will be towards sound side. Inferior muscles are paralyzed, head tilt towards ipsilateral side. It's a clue. Superior rectus, sound side tilt. Superior oblique, sound side tilt. Inferior rectus, same side tilt, ipsilateral. Let them say clue. That way you can have a clue and see the patients. Then of course when you say a case of ptosis, you have to measure the ptosis, degree of ptosis, then you have to know about the L-based actions. You must examine all those things, you must tell in the exams. Accordingly, you have to tell the treatment has to be modified. Okay, depends upon the L-based actions, depends upon the degree of ptosis you have to modify. So next you have to do Marcus gun. When you see a case of ptosis, always remember you have to look for Marcus gun. Here one classical clue is that if you see that lid crease line, please remember, if you have got a lid crease line in this area, this lid crease line is there, think the patient will have Marcus gun. Lid crease line absent he may not have, because the lid crease line indicates what, man? It's an attachment of LPS. Attachment of LPS. Only when the muscle is well developed, naturally you can have a lid crease line. So when the muscle only developed, only we can have an elevation. That is why if you have a ptosis, if you have got lid crease line is very nice, nicely seen. In this case, you are supposed to have Marcus gun. It's a classical thing we'll ask in examinations. Understand now? Okay. Next, of course, I told you hemiplegic gaits and all these things. Next is now, of course, you have to examine vision. Then gait, tremors, all these things are supposed to look for. Then I told you, when you examine the missing letters and all, hemianopy patients can have problems. Sometimes crowding phenomena will be there in the case of amblyoppias. Then you have to see the patient. When you take the visual acuities and all these things. Then I told you this. Okay. Then movements, most important. When you see the movements, pursuit, you know that, how to do the pursuit movements. Saccadic means you give two fingers like this, ask him to do alternating look, or vertical saccades like this. Like this, understand now? Saccades, mainly initiated by your frontal lobe, exam question now. saccades are commanding from where? Get command from where? Your answer is frontal lobe. Then for pursuit, where is the command coming from? Your answer is occipital parietal. Understand now? This is the common question we'll ask you. Front, saccades and all these things. Then you got, when you see the movements, never forget about the lids. See, when you move the lid can come close. When you move this side, lid may open. That is widening, short, something, narrowing up alveolar apertures, you can see. Similarly, when you ask if you look down, you can have a lid gland. That means what? You are going to see where is the case of thyroid, where is the case of what? Duane's. Always remember, when you examine the movements, never forget to see the lids as well as the alveolar aperture. See for any overactive metals, all these things. All these things are supposed to write down. Okay? Then see for Bell's phenomena, then all this. The reason, why I'm having movement problem, man. But Bell's phenomenon is present. That means you are dealing with a case of supranuclear palsies. Normally we don't give a case of supranuclear, but we'll ask you questions. How do you know it's supranuclear? The answer is, please remember, during movements of problem is there, but they will have dorsal movement is present. Then Bell's phenomenon is present. That means it indicates it's supranuclear palsy. And one more thing is there, diplopia, please remember, is absent in a case of supranuclear. Diplopia never will be present in a case of supranuclear palsies. Only nuclear and infranuclear they can have diplopias. There are common questions when examination will ask you. Of course, cover and uncover test you are supposed to see. Now the pupil, you are supposed to see the reactions, size, shape, see for anisocoria. Now your common question is what? Anisocoria is there. How do you know it's physiological? You put a light, the pupil contracting. Suppose imagine now the difference in size is only 1 millimeter now. Before reactions. Now I put a light, they are contracting, the difference again 1 millimeter. That means the difference is maintained in all reactions, it is physiological. Imagine now I am in third palsy. I put a light, people may not contract. That means what? Third palsy when I put a light, initial difference was 2, I put a light, now the third palsy people will not contract, normal people contract. So the difference will get aggravated. It's a pathological problems. So please remember the exam questions. How do you know it's physiological? Your answer is, in reactions, if the difference is maintained, it is physiological. In reactions not maintained, it is pathological. That's all you are supposed to know. And then of course you should know the light reflex pathway, accommodation pathway, all these people's reactions, all these things. You must be knowing something about the AIR people, something about ADS people. I'm sure now, all these things you are supposed to know. That will count and not. If you want to know, we can have a class 24 hours. Hello. We can have full day class so that you can understand neuroophthalmology very well. It's not difficult. One of the easiest subjects in the whole world is bloody what? Neuroophthalmology. Okay. Then I told you anisocoria. Okay. Then I will show the RAPD, optic neuritis markers and people you are supposed to examine for that. Then finally, finally never forget to examine the fundus man. Fundus, 6 palsy will have papilloma. Then diabetic changes are there. You can straight away come to a conclusion, this is a case of diabetes. Hypertension is the reason. Then sometimes they will have RP. They can have Kearns-Sayre syndromes. You know that. RP patient can have a Kearns-Sayre mitochondrial inheritance problems. You can see the fundus and come to a conclusion. Finally, when you tell them, you are supposed to take diplopia charting in the exam hall. Okay, exam hall you are supposed to do diplopia charting. I hope you know that. If you want to know, come, hello. You can, all of you are welcome to Coimbatore to Dr. Sanichai's clinic. Hello. We will come there, take a class for 2 days, don't worry. Okay, finally you tell which nerves that are involved, site of lesion, what's the most probable etiology, people is bad or not, like that you are telling the exams. Then you tell about the diagnosis, and then you tell about the investigations. Don't tell urine, bullet, all these things. You must take a diagnosis, MRI, straight away tell the diagnosis. Understand now? Don't tell, I will take a DC and all. Some diet, something investigation to clean the problem. That's the most important thing. Understand now? This is the way of the answer the exams, and it's very, very easy to clear the exams. Very, very, one of the easiest subjects in the whole world is ophthalmology. Don't bother. Understand now? Thank you.